So now let's move on to nuclear scintigraphy. Now this is not new, okay? This has been around since the 70s, okay? But heavily in the United States in the early 90s. And in my opinion, has still never caught on for what the amount of information that it gives us, again, specifically with dressage horses. What I can tell you, and I've been bone scanning for 14 years now, what I can tell you about dressage horses is for some reason, and you guys are all going to say we know why, our horses work harder than other disciplines. Dressage horses have much more uptake of radiopharmaceutical in their skeleton when we do the bone scan, and much more increases in uptake, these black spots here, than any other discipline I work on, including racehorses. And so what that, Dr. Rantanen is my colleague, the radiologist that he and I work together on imaging. You know, he says, well, it's probably all that repetitive motion constantly that the horses are constantly remodeling their skeleton. So how does it work? We inject a radioactive compound that's labeled to a bone-seeking agent, and it goes into the body. So there's a normal uptake. So here's the knees, you're the camera facing the horse. So here's the front view of the carpi. And this is normal. There's a little bit of an increase around a joint because of the physiology of a joint. But then you've got these patterns, whether it's black and white or this brownish yellow that I've got here. It shows up because bone is remodeling on a daily basis. We're sitting here and our bone is remodeling. But when there's an increase in remodeling, there is this, what we call a hot spot. It has nothing to do with heat. It has to do with bone remodeling. Okay? So that's the concepts behind nuclear scintigraphy. Injected with a radioactive compound, we can look at the soft tissues immediately after injection. So here's a horse with a branch lesion in the suspensory and a little bit of a problem at the fetlock joint. And this is immediately after we've injected it, where it's present in the soft tissues. That's called the soft tissue phase. And then we can come back, as I just showed you, and we can look at the bone. And this is the classic of where nuclear scintigraphy started, and that was looking for these stress fractures. This is a horse that was lame, and they couldn't find anything with the x-rays they took, and so they referred it in, and you can't even see the other leg. The other leg is there, but there's so much remodeling there that it's completely obliterated whatever we can see from the other leg. And then once you know it's there, then you can be more aggressive with your views, and this view, after probably 10 views, we can finally see the fracture right there. This is what nuclear scintigraphy started for. Okay, was to pick up stress fractures, and it's evolved from there. So let me show you our setup here in Southern California. This is our unit. I tell people this is the x-ray machine, this over here is the MRI that we're going to talk about in a minute, but the bone scan, it's into the floor here, so we can do all the way down to the horse's foot, and then it comes out of the floor and can go up over the top line, and we can basically do the entire horse with that. So it started out looking for stress fractures in racehorses specifically, but it's evolved to a much, much more important tool for us, particularly with dressage. And so I'm going to tell you about some fancy words here that mean a whole lot to me with sport horses and dressage horses. Enthesiopathy, okay? Enthesis uptake. So, do we have any MDs in the room? Oh, right. Enthesis, in Dorland's medical dictionary, enthesis is the region of soft tissue insertion onto bone. Okay, and so in this particular histo from my PhD work, you've got the joint capsule here. This is the fetlock. This is the distal metacarpus, proximal P1, and the sesamoid bone. So you've got joint capsule here and here on the front and back. You've got the distal sesamoidean ligaments. You've got tendons. You've got ligaments. Everything has to insert onto bone in order to work. So that's the enthesis. When you have enthesis uptake, we've been calling it for about 10 years enthesiopathy. In other words, a problem with the insertion of soft tissue onto bone. It happens in people. You've got the plantar fasciitis in your foot. You've got patellar tendon pain. You've got tennis elbow. All of those are enthesiopathies. But it's the most common problem that we see in warm bloods in particular. And the problem with it is it's almost impossible to diagnose those without a bone scan. And so here's a fetal look at that interface between a ligament. This is between two carpal bones. This is a ligament here, and this is the forming bone. And you can see that there's a gradation between the fibrocartilage layer between the ligament and into the bone. And that's where these ligaments are anchored into the bone. And that's where a lot of our mature horses will get stressed. So the ones we know for sure, the easy ones that everybody's heard of, is the origin of suspensory. So this is a forelimb. This black spot is the origin of suspensory in both forelimbs there. Big, huge problem with the origin of suspensory. And then in the hind leg, same thing. That's a problem where the suspensory attaches to the bone. We've been talking about that for years, so hopefully everybody's heard of that. But then we've also got patterns in the foot now. So this horse has that pattern there in the foot. That's not the navicular bone, which would be back here. It's the soft tissues in the foot. Well, we've been doing more with that recently, and we found that, and part of this then has to do with the MRI, where we can see these focal spots in this horse's foot, and we can see this big increase in the wing of the coffin bone on that horse, and a lot of that has to do with the soft tissues that insert there, the collateral ligaments. And this will make horses sore, and nothing shows up on the x-rays, and so you're left with wondering, well, we've blocked the horse out to the foot, we've taken radiographs, we don't see anything, and yet the horse is lame. What's causing it? Well, it's soreness, and I'm not even going to say that it has to be a terrible lameness, but it's soreness at that insertion site. So 2 more reasons that bone scanning is very important for mature sport horses, particularly dressage, are here's 3 sets of hocks. One, a right hock on top, and the horse is backed up to the camera down below. And we've got 3 different patterns up here that all would block out similarly and would all have similar gait deficits, decreased flexion and decreased protraction of that hind limb. This is a relatively new one for us, where we think it's a ligament on the plantar aspect of the hock. This is the joint, which would be the arthritic case, and this is that origin of suspensory. And they're all going to require different treatment. So that's the goal of trying to figure out. This horse was very lame 6 weeks ago. She just called me on the way to the airport yesterday and said completely sound. He didn't even like me flexing his leg, and he was 3 out of 5 lame. And with a couple of focal shockwave therapy right over that spot, she tells me he's completely sound, and they're thrilled. So we'll talk a few minutes about treatment as well. And then the other reason for bone scanning, very common in the dressage horse, are Topline Syndromes. This is the sacroiliac joint here on a skeleton, and we're looking at through this region here on the normal pelvis, and on the abnormal one, that's a very obviously abnormal sacroiliac joint. Very common problem in dressage horses, especially when that parking brake feels like it just went on. It might be that they're having an issue with that. And the other one that's very common in our caseload is the cervical facet arthrosis, or the problem at the neck. This is the shoulder, and this is the first vertebrae, that's the first joint, C6, C7, just cranial to the neck, and that very obvious abnormality there compared to the ones going forward, and this is the other side of the neck. So it's a one-sided problem on this horse, and it's an arthrosis that's almost impossible to diagnose on most of the dressage horses unless they have a bone scan. And just a word on the fact that if a dressage horse does not seem lame, but he's not going forward very well, relatively suddenly, these 2 problems, that sacroiliac top line and the base of the neck, are 2 of the more common problems in our caseload that's causing a dressage horse to not be as supple and not be as willing and not be as forward as he has been. Okay, going to move on briefly. I see my time. So we're going to talk about MRI now, because that's been very exciting for all disciplines, particularly dressage. So we now are able to do MRI. In my practice, we have the standing unit, so we actually do it standing. This is the magnet here. We put a little coil around the horse's foot. We tranquilize them, and we have a nice little pad there so the horses rest their head and just think pretty thoughts while we take their images. So what it is about MRI, a lot of you have probably had it, but the thing, especially in the standing horse, and there's a lot of units around where you can anesthetize a horse. Florida, University of Florida has one, and a lot around the nation where you can anesthetize and get the same thing. But the bottom line is we can slice. Once we position the horse, we can slice in different planes and take different contrasts and see different tissues. So here's a sagittal view of the foot. This view here, navicular bone, coffin bone, P2, we never had that view prior to a postmortem examination without MRI. We can see things that's just phenomenal. Then we take a transverse oblique so we can see the navicular bone and the flexor tendon. We take a frontal plane there so we can see the collateral ligaments here. And then we take a horizontal transverse where, again, we look at the collateral ligaments and the soft tissues in the back of the joint. So without moving the horse, and hopefully they don't move, but sometimes they do during the process and we reposition them. But without moving the horse, we can see all these different planes, as well as then change the contrast and see the different tissues. The ligament, the tendon, the bone in ways that we could never see before. So just a few things on that. What we've done now is we've been looking at and again, 14 years of bone scanning, 4 years of MRI. There's still a learning curve for us, but we've put our numbers together for several meetings recently. And when we're looking at obvious navicular disease, it's a big, huge hole in the navicular bone. That's quite obvious. That's not that common. It's definitely not common in dressage horses, much more common in the quarter horses, as you'll see. But a lot of these horses will all have increased uptake in the navicular bone here on the bone scan, and there's another big defect in the navicular bone. Both of these horses didn't have radiographic changes that we felt were associated with this severe an injury. And then you've got what's more common in the warm blood and then dressage horse is navicular inflammation. So they'll have uptake on the bone scan, but they'll just have fluid in the navicular bone, and that is usually not as serious and more amenable to treatment. And then the impar ligament, where it attaches to the navicular bone there, and where the soft tissues of the deep flexor tendon inserts onto the coffin bone. So all of these are things we're finding. This is the exciting one for us, the collateral ligament injury, simply because collateral ligaments of the foot, of the coffin joint, most of it, this is the level of the coronary band right here, and this is the collateral ligament. The normal side here, and all this white in here is the abnormal side. Okay, so again, all this white is abnormal. It should be black like that. Most of the collateral ligament is below the hoof wall. And so we call it the emperor's new clothes diagnosis, because if we couldn't see it, they must have never injured it. Okay, and we're not finding that to be the case at all. In our caseload, it is one of the most common soft tissue injuries of the foot in warm bloods, both show jumping and dressage. And then it can be even more serious where they've actually pulled it out of the coffin bone, and there's a big hole there in the coffin bone where the ligament inserts. Interestingly enough, and I just had a horse recheck 2 months ago with one of these injuries, and it has totally healed. And that horse is back in full flat work, has not started jumping yet, and completely sound. So I'm excited because the problem is these were very difficult to impossible to diagnose in the past, and yet they might block out like what we used to call navicular syndrome. The good news is that they're treatable, and I'll talk about that in a minute. And then the last of the big diagnoses in the foot is the one that I really don't like to make. I tell all the clients when they're coming in for an MRI, I hope it's not a tendon tear, a tear in the deep flexor tendon below the area where we can ultrasound it. So between those yellow areas is a common spot. Sometimes it's across the navicular bone, and sometimes it's here. This, you can see, this should be a nice bilobed structure of the tendon, and it's got degeneration of both lobes there. This actually is a dressage horse. This one was a show jumper. And the point is that the reason I don't like that diagnosis yet is because we have not, worldwide, the international community of people doing MRI, we get together and have meetings. We've not yet come up with a definitive treatment or a treatment that I think is head and shoulders above the rest for tendon lesions. So we've in our practice, we've tried pretty much everything that's been discussed and we could think of, from rest through injecting with stem cells and things like IRAP and surgical debridement. We've tried them all, and none of those has shown that it's any better than the other. So a lot of our clients have been trying rest.